Hello, I'm Mary Slavin, and I want to, can you go back a slide, please? Hi, I'm Mary Slavin. I'm the Director of the Dissemination Core and Co-Director of Education Program for LeaRRn, and I'm pleased to introduce today's presentation in our series called Using Health System Research to Revolutionize Rehabilitation Care. And while we're waiting for people to come in, I just wanted to make sure everyone is aware that we have closed captioning to provide accessibility. And this slide provides some instructions on how to access the closed captioning capability. You can either use the More option or the Shows caption. It will also display the presentation in other languages, should you want that. And next slide. And I want to make you aware of some other events that we've had recently. There's two archived events. Our most recent ones are a webinar that Dr. Anna Baumann provided to us on enhancing representation strategies to engage diverse participants in research activities. And then we also had Dr. Leo Cabasa present a webinar on equity-grounded implementation science exemplars from the field. Next slide. So, as you're all here today to hear our speaker, Amanda Botticello, and her talk is on neighborhood socioeconomic differences and race disparities, findings from a national registry of people with living with spinal cord injury. And I just want to introduce our speaker. So, Dr. Botticello is the Associate Director of the Center for Outcomes and Assessment Research at the Kessler Foundation in West Orange, New Jersey. She's affiliated with the Department of Physical Medicine and Rehabilitation at Rutgers New Jersey Medical School, where she's both research professor and vice chair of research education. She conducts research on the social determinants of health and disability with a focus on environmental factors, addressing barriers to community reintegration for both adults with spinal cord injury, children with special health needs, and other populations with chronic health conditions such as TBI, MS, and psychiatric disabilities. She is the current co-investigator for the Northern New Jersey Spinal Cord Injury Model System, which is a NIDLR designated model system of care. Dr. Botticello is the current project director of a center grant from NIDLR, building research infrastructure to investigate the social determinants of health after spinal cord injury with an emphasis on the environment. Dr. Botticello is trained in social epidemiology at the Fielding School of Public Health at the University of California, Los Angeles, where she received her MPH and PhD, and she holds a BA in psychology from Amherst College. And with that, I want to welcome Dr. Botticello. And just so that you know, we have an agenda that will be starting with this description, followed by Dr. Botticello's presentation, and we conclude with a live Q&A session. So we ask that you post your questions using the Q&A feature of Zoom, and we will organize and address those questions at the end of the presentation. And with that, I want to welcome Dr. Botticello and thank her for joining us today and for sharing her expertise with this audience. Thank you again.
Hello, thank you so much, Mary, and thank you everybody for attending and for the invitation. So I'm just going to launch right in. So as Mary mentioned, these are my credentials and my background that gave rise to the content that I'm going to be presenting to you today. I also wanted to mention that
I want to make sure that you're sharing your screen.
Oh,
yeah.
So sorry about that. Just a second, everybody. All right, how are we doing now?
Just go into presentation mode.
Okay. Just give me a sec.
Yeah.
Good now.
Perfect, thank you.
Okay, thank you. It always takes a minute. So once again, thank you for inviting me today. One of the ingredients of this talk that I also wanted to mention was that this project has been funded by a grant from the National Institute on Disability, Independent Living, and Rehabilitation Research, also known as NIDLR, which is within the Administration for Community Living and Department of Health and Human Services. We're very grateful for this support from NIDLR, but it is worth mentioning that the contents of this talk do not necessarily represent the policies of NIDLR, ACL, HHS, and that you should not assume endorsement of the data by the federal government. So we have a few objectives today, and overall the goal of this presentation is to impart upon everyone attending the importance of neighborhoods to understanding community living outcomes for people with disabilities. And in designing this work and this talk, a few of the takeaways that I hope that you get are for us to demonstrate the potential of longstanding data resources that are available to us to understand neighborhoods within the field of medical rehabilitation, to identify best practices that are currently in use for developing neighborhood measures and indices of communities and so forth, and to discuss some potential applications to health disparities research. So to begin, and I think this is very familiar to the LeaRRn audience, but it's worth lingering on for a moment, are just the true importance of the social determinants of health to all people in all aspects of life. So these are really the conditions in which people conduct their activities of daily living, and they're present everywhere in the places not only where people live, but also where they work and socialize. And differences in the presence and the quality of many of the social determinants of health, including economic factors, education access, healthcare access, the built environment, and the social and community factors can have a strong impact on inequalities in a broad range of health outcomes. And this has been proven time and time again in social determinants of health research. But one of the things to really consider is how the presence and the quality of the social determinants of health can make a particular difference to the health and well-being of people with disabilities. The social determinants of health are actually very well aligned with how we understand disability currently, which is not necessarily the inevitable outcome of a health condition, disease, or disorder, but it's actually an interaction of numerous factors that are going on at both the individual level in terms of body functions and structures and contextual factors. So the WHO has given us a very nice framework for understanding disability as the result of the conditions in which people live. And then again, this is aligned with more broadly in terms of public health and how we understand the health of all people. Another thing that I would like to discuss before we get into the nitty-gritty is just the case of spinal cord injury. So you'll notice the examples that I'm citing include people who are living with paralysis who oftentimes use wheelchair or other assistive technology for mobility. So spinal cord injury in the United States, and in particular, I'm going to discuss traumatic spinal cord injury, is the result of damage to the spinal cord or the spinal root nerves within the canal, and it can result in temporary or permanent loss of movement or feeling. This can happen by numerous routes of etiology, but most common in the United States is a vehicular accident followed by falls. There are over 300,000 people living with traumatic spinal cord injury and permanent paralysis in the United States, and we estimate that there's over 18,000 new injuries occurring each year. Over time, spinal cord injury has changed. When we started tracking spinal cord injury and outcomes in the United States in the early 1970s, the picture was a little bit different. It primarily affected people in young adulthood. Hospital length of stays were much longer. But over time, and most recent estimates are from 2015, we found that people with spinal cord injury are increasingly being injured at older ages, but also hospital length of stays have decreased dramatically. And as I mentioned earlier, many people with spinal cord injury go on to live full lives, and this is oftentimes helped by access and use to assistive technology. But as you can imagine, thinking about the social determinants of health and environmental factors as we understand disability, there's a very critical need to understand the role of the environment, so neighborhoods and community, and how that impacts community living and health for people with spinal cord injury specifically, as well as other people living with mobility impairments. It's also really critical that we understand neighborhood and community from a point of view of rehabilitation. So, getting people back home, back to the community, and living as full of lives as they would like to live is, of course, our ultimate goal for many rehabilitation programs. Also, as length of stay has decreased, people are returning to the community sooner and oftentimes continuing the work of rehabilitation and adjustment after they've left the hospital within a context that they are now having to experience in a different way and learning how to do things that they used to do in a new way. So, understanding the role of an environment is really critical from two facets. Overall, as a society, it's important for us to think about social inclusion for people with all ability levels and how the different social determinants of health can impact that. But also, in terms of healthcare provision, it's very critical that we understand the role of a neighborhood environment because that's where most people endeavor to live. They want to live full lives in age and place, and we need to do a better job of supporting that. One of the resources that we have to really understand the picture of spinal cord injury and how this has changed over time, as well as the scope of rehabilitation outcomes and what is really important to people is a data resource known as the Spinal Cord Injury Model Systems Database. So as Dr. Slavin mentioned, I've been a longtime investigator involved with this consortium. It's a prospective cohort study that has fostered a registry of people with spinal cord injury starting in 1973 and continuing to this day. So in some parts of the country, we have people within our database who have been participants for over 50 years. Almost 55,000 people have been enrolled to date, and of that, a strong subset has enrolled in longitudinal data collection. So we interview people and start to obtain information about their overall background, health, and well-being when they're in the hospital using a combination of interview and medical records. And then we follow them up over time, 1 year after they've discharged to the community, and then every 5 years. And I should also mention that this database is a hospital-based sample. So we've had numerous rehabilitation centers involved since its inception, in fact, over 32. And currently we have 18 model system centers funded across the United States, which I've pictured here. A great thing about the model systems database is we have numerous data elements to really investigate the full scope of disability that's depicted in the ICF model. And among these are geographic identifiers that allow us to link the database to other administrative data sources that can be used then to create measures of many of the environmental factors that we've theorized are critical through the social determinants of health framework to foster good health, well-being, as well as economic engagement and social engagement. So within the SCIMS database, we have a range of census tract indicators known as federal information processing codes, as well as location coordinates. So by that is typically latitude and longitude of somebody's residential address, as well as zip codes. And then these two data sources, whether it is from the U.S. Census Bureau or other administrative data sources, can be linked to our health survey data. And using this resource, we have done a small number of studies to date that have demonstrated the importance of neighborhood as a social determinant of health to spinal cord injury outcomes and community living. We focused most of the research to date on neighborhood economic conditions, and what we found are patterns that are broadly consistent with what we see in the general population. So in other words, people living in areas with higher rates of socioeconomic disadvantage are also at increased rates for obesity and poor quality of life, whereas people living in areas with high socioeconomic status are reporting better health, higher rates of community participation, and higher rates of employment. we have a small number of studies that have occurred to date, and there have been some barriers to continuing this work. Number one, this work has been slow to progress because of privacy concerns. So using indicators such as geographic identifiers or spatial coordinates are a type of personal health information. It is not an insurmountable challenge, but it is a barrier to researchers being able to use the data at a rate where we would really be able to expand this body of work. It also takes a good bit of time, effort, and expertise to be able to build measures from administrative data sources that can be used to productively examine the role of the environment that is well conceptually grounded within our current understanding of the social determinants of health. And then finally, another approach that's been frequently used to mitigate some of these concerns are using pre-existing neighborhood indices. And there are a number of them, as this type of research has been well documented in the general population, and there are many tools that are now widely available that will help a research team, for instance, link to an environmental factor and then conduct an analysis. However, there's some important caveats to consider when adopting a pre-existing measure. Most of the tools, to our knowledge, that are available were developed with cross-sectional data, and some of them have not been updated to reflect current income levels or access to technology. A number of pre-existing measures have been developed for specific uses in population that may not be generalizable to rehabilitation populations. And then finally, and this is something that I would like to emphasize, it is always critical to have conceptual clarity when developing measures so that we're sure that what we're using is truly getting at the key constructs. So from here, I'd like to talk about some current work that we're doing to address some of these caveats and move the field forward, at least within the realm of spinal cord injury and medical rehabilitation research. So we have what is called the SCIMS EFD project, standing for the Spinal Cord Injury Model Systems Database Environmental Factors Dataset. It's a little bit of a mouthful, but our overall goal is to improve and enhance social determinants of health research and improve our surveillance of the spinal cord injury population by creating a series of user-friendly data sets that can be integrated with the national database and readily available for researchers to use with our publicly available data set. We are also being sure to follow best practices for measurement development, and I'll explain what that is in more detail in a moment. And then finally, use some of these measures to really advance the field in terms of health disparities research. So best practices. Well, very fortuitously, as we embarked upon this project, we came up, or rather found a great resource that was published recently in the Journal of Epidemiology and Community Health by Alec and colleagues that lays out very definitively the steps that one should be following when creating small area measures. And by small area, neighborhoods and communities have different definitions. We largely use administrative definitions to define an area where someone lives, but there is some variation there. So using this framework, we also added, again, what I think is critically important, to define concepts of measures of neighborhood before embarking on any kind of index or neighborhood measure development. And so we started our project looking back at neighborhood economic conditions because we felt it was very important to start here, given the wide breadth of research that exists in this area and the critical importance of neighborhood socioeconomic status and socioeconomic disadvantage to looking at population health surveillance. So these are resources that are external to the person in the place where they live, but we really want to differentiate between what we mean by that. So socioeconomic status is one's relative position within a society, and it's usually defined by variables such as income, education, occupational prestige, and assets, whereas socioeconomic disadvantage is a lack of resources that are needed to maintain an adequate standard of living in a given context. And the usual variables that we think of in that sense are things like poverty, a lack of access to resources to meet basic needs, employment, housing, and other types of resource access. in the prior literature and in some of the pre-existing tools that have been used over time, these things are sometimes conflated. And we thought that it was very important to establish conceptual clarity at the outset of measurement development. We also thought it was critically important to consider factors related to social disadvantage. And this is because some of these indicators have been included in prior indices, but it's not always clear that groups that are at greater risk for low socioeconomic status or high disadvantage should be included in an overall measure of socioeconomic status itself, just because of historical or systematic barriers to opportunities for advancement. So in other words, indicators of social disadvantage are more of a societal indicator and not a risk factor in and of themselves in this context. But of course, this needs to be shown analytically. So one of our next steps was to develop our study for analysis. So our administrative data resource was derived from the American Community Survey. And this is a Census Bureau product that is routinely administered and updated and widely available and representative of the U.S. population. We also selected our level of geography as the census tract because it is the most frequent proxy for a small geographic area in prior neighborhood research. And it's also widely available for most of the participants in our SCI model systems database over time. The ACS data is available through several routes, but the one that we find is the most user-friendly and accommodating is the IPUMS data. So this is a great resource. I highly recommend it for census products and other national administrative data sets. It's very user-friendly and easy to work with. We extracted the 5-year ACS estimates, which give you the most coverage for the U.S. population, and it's also available over time. Which again, getting back to one of those critical caveats that we want to address, is looking at developing indices that would be robust for a prospective cohort study that has continued for a number of years, and we hope continues for a number of years forward. So we extracted several vintages from the ACS that would align with when we had the most census data elements within our data set. Our next step was to select our indicators, and for this we really looked at what was available in the published literature and did a thorough search of the most popular indices that are used within US-based research, and I've named a few of them here, although certainly there are many, many more. And then within those indices, we extracted 48 economic indicators to represent numerous subdomains that would really represent the conceptual domains that we laid out at the start of the study. So socioeconomic status, socioeconomic disadvantage, as well as the characteristics of disadvantaged groups, which we wanted to assess to see whether or not these would be part of a socioeconomic or economic factors data set or something that should be included as its own entity. And I can't emphasize enough in terms of this type of measurement development how important it is to cast a wide net rather than making a priori decisions before you've looked at the data to see what factors are important, both conceptually as well as from a results or a data perspective. Our next step was to construct the index by selecting indicators using a scientific review panel that was brought together for their expertise not only in measurement development and epidemiology, but also spinal cord medicine and rehabilitation medicine. Our group or our panel reviewed the 48 indicators that we selected for several selection criteria, which are commonality or the frequency of use, stability over time, data availability, so what would be available and likely collected by the U.S. Census Bureau through the ACS over time, and finally, generalizability to SCI outcomes. From the 48, our panel selected a final data set of 29 indicators to develop our index. And I've given a few examples here of exclusions because I think it's really important to understand while all these indicators are important and may be important in other contexts, we felt that these would be the most important for our data set going forward. along the lines of frequency of use, stability over time, data availability, and generalizability. To construct the index, we used the most recent ACS that we had aligned with our spinal cord injury data set. So we used the 2019 American Community Survey 5-year estimates, which represents over 70,000 census tracts. And we had several steps to our analysis for constructing the index. So we used pairwise correlations to really screen out any irrelevance or redundancies among our selected indicators. We conducted an exploratory principal components analysis that used several criteria to select factors. And then finally, based on the number of factors identified, we did a final PCA to get component scores. And this is the upshot of that process. So our PCI identified 2 components that largely fell out along the lines of our hypothesized constructs of socioeconomic status and socioeconomic disadvantage. Some examples of our non-salient factor loadings, which are again along the lines of what we hypothesized, which were important social characteristics, but not inherently disadvantaging in and of themselves, or race, ethnicity, language, disability status, and health insurance. And then we replicated these findings over time with 2 other vintages from the American Community Survey in 2009 and 2014, and then using the Spinal Cord Injury National Database. So just to linger a moment on which factors comprised our eventual indices, for neighborhood SES, we found that the most highly correlated and cohesive factor loading variables were percentage of college graduates, households receiving interest income, so in other words, assets, the number of people in managerial or high prestige occupations, median household income, and median home values. Whereas neighborhood disadvantage consisted of variables related to unemployment, poverty, receipt of public assistance, single-parent households, the number of households that did not have access to transportation, and renter-occupied households. And then depicted below, not included in the indices, but we retained for further analysis and use, were important social characteristics such as percentage of people with a disability, the number of people within a census tract of ethnic and racial minority backgrounds, and the number of people, or rather percentage of people who spoke English as a second language, and the number of people, or percentage of people who are uninsured. Our next step in the neighborhood indices development process following ALEC's model was then to do a predictive validity analysis. And we did this using the spinal cord injury model systems data set. We used a sample of people who were interviewed between 2017 and 2021. So we had about 8,100 cases to conduct this analysis. Our outcome was the overall percentage of people reporting poor health versus good health. We used logistic regression and reported the results in terms of odds ratios, confidence intervals, and predicted probabilities, which I will show you next. So this is an overall summary of our model using our neighborhood socioeconomic status index to predict the likelihood of poor health across 3 tertiles of neighborhood. And what we found, if you look at the solid bar on the left, is a nice gradient between the likelihood of people reporting poor health and the overall type of neighborhood that they lived in. So low, moderate, or high SES. We found that when we accounted for personal factors, particularly personal income access and personal education, this difference was completely attenuated, suggesting that the effect of neighborhood socioeconomic status with respect to the poor health outcome is compositional. In other words, the effect that people have on places. Our second part of the analysis was to look at our socioeconomic disadvantage index and the likelihood of poor health. And what we found, similar to socioeconomic status, is a nice gradient, albeit in the reverse direction. So if you look at the solid bar that I've depicted on the left, there is a grade-wise gap between people who live in low, moderate, and high disadvantaged neighborhoods and their likelihood of reporting poor health. When we accounted for differences in demographic background characteristics, employment status, and spinal cord injury type, this difference was mitigated, however, not fully, suggesting that the effects of disadvantage on poor health are contextual. So, in other words, the exposure to adverse circumstances, be it low employment, higher rates of disadvantage, less resource access overall in a community, affects the likelihood of people perceiving their health as poor over and above their individual resources, income, and education. The last step in the neighborhood development, or rather the index development process, was to assess uncertainty. I'm not presenting the results of that here, but just it's worth saying it's critically important to also compare the confidence intervals, look at the difference between the continuous and categorical versions of these measures, and ensure that these conceptual variables actually do distinguish between areas that are high and low values. So, in the last third of this talk, I just wanted to talk a little bit about some applications that we're currently conducting among our research team to look at how well our indices that we've developed can be used to in neighborhood and racial and ethnic disparities research. And so we have 3 analyses that we're currently conducting, and I would like to give a nod to some of my colleagues on our team. So we're looking at the relationship between neighborhood economic conditions and the likelihood of employment after spinal cord injury. So employment is a big part of community participation, and for people with spinal cord injury, rates of employment are historically low. Only, an estimated 5 to maybe 30% of people go back to work after injury, and this is something that has considerable economic as well as social consequences, both for people and the community in general. We're also interested in looking at the relationship between neighborhood economic conditions and obesity. So this has been a topic of great interest in the general population. And for people in spinal cord injury in particular, they may face significant challenges to actually maintaining a healthy weight after injury due to limits to mobility and physical activity. And then finally, there have been well-documented disparities in rates of community participation overall between racial and ethnic minority groups and other groups. So we are interested to see if neighborhood differences can perhaps explain some of these disparities that we're observing, because social inclusion for people with disabilities is overall in rehabilitation one of our most important goals, and we want to make sure that we have better equity and access for all people to be included in society. So just a summary shot of our work in employment, and these are preliminary findings, is we find actually that differences in the likelihood of employment are strongly related to differences in neighborhood socioeconomic status. So these are overall indicators of, again, economic opportunities and access. We find the probability of employment is highest among people who live in high SES areas, and this is over and above people's own resources and background, so educational attainment, as well as prior occupational status, suggesting that living in areas where people overall have higher rates of employment and other types of background characteristics is beneficial for people with spinal cord injury in terms of obtaining a job after injury. We also found a modest difference by neighborhood SES in average rates of body mass index. So average BMI was higher among people living in low SES neighborhoods compared to people living in high SES neighborhoods, suggesting again opportunities to intervene and perhaps look at people who may need more assistance and places for us to target our programs to ensure that people with spinal cord injury who live in areas at risk may have more opportunities to maintain a healthy weight. And then finally, we're very interested in re-examining some of our prior work in community participation, showing health disparities in overall rates of community participation and social integration reported by people with SCI. And what I've depicted here shows some of that mediation effect by neighborhood SES. So in the first model, model one on the left, we see actually large gaps between non-Hispanic Blacks and Hispanics in terms of overall reported rates of social integration. When we account for differences in neighborhood socioeconomic status, we found that this gap was fully attenuated for Hispanics and partially attenuated for non people who identify as non-Hispanic Black. And then when we accounted for personal differences in both background and economic characteristics, the difference for non-Hispanics Blacks was further attenuated, but also persisted slightly. So in other words, this indicates the importance of looking at both neighborhood effects as well as personal background factors when we consider health disparities. I also want to mention that our differences overall by neighborhood, which aren't depicted in this graph, over and above race ethnicity persisted, suggesting that neighborhood and racial and ethnic disparities are related, but they don't overlap entirely. And this is something that needs further explanation or exploration. Okay, so I would just like to end my session of today's talk by talking about next steps and how other people interested in using some of the measures that we've developed or perhaps using the approach that we've implemented can learn more. And one of the things I would like to point out is that we recently published our process and this work in the archives of PM&R. And that article is available open access, and I'm happy to provide it for anyone who would like to have access to it or some of the supplemental information and data that we used. We are also archiving the SCIMS EFD, so our environmental factors data set, with the National Spinal Cord Injury Statistical Center. So this is housed at the University of Alabama in Birmingham. A limited data set is available to independent researchers who want to collaborate with this network. And now that we have done the work of developing these measures, they are linked with the spinal cord injury model systems data set, and this mitigates some of those barriers I mentioned earlier on to conducting this type of work. So in other words, by having these variables appended to the data set, we avoid having to use things like PHI and develop our own measures. And hopefully this will streamline the process and spur greater use of these variables in either further neighborhood investigations or surveillance work with spinal cord injury. The SCI model systems dataset is also publicly available, and I would be happy to connect anyone who would be interested in learning more. Finally, I did want to mention, this is an ongoing project that's funded by NIDLR. We have several aspects of the community and neighborhood that we are developing measures of using administrative data sets. So we're continuing to build the SCIMS EFD. We've been working more recently on measures of the built and natural environment, as well as healthcare access and healthcare quality. And will definitely be interested for anybody who wants to follow this work and learn more in reaching out to you after this talk. And our hope is really that these social determinants of health variables will become standard in SCI surveillance, but also in other outcome studies and networks that are currently being used in medical rehabilitation. Oh, and really quickly, I just wanted to give a big thank you and acknowledgement to our study team. So this is the panel of experts that I mentioned earlier. We are 4 model systems centers currently funded this cycle who banded together in this project. So I have my colleagues here at Kessler Foundation, as well as Baylor Scott and White Research Institute in Dallas, Texas, Craig Hospital in Englewood, Colorado, and the University of Alabama in Birmingham. So at this point in time, I would just like to leave you with my contact information. Please feel free to reach out. Thank you very much for attending today and for your attention. And I will stop my share and turn it back over to Dr. Slavin.